Healing Hands Health Society presents Dental Webinar Series. We have planned a series dental webinars to keep you abreast of current practice. This series on prosthodontics will be via Zoom, Facebook Live. Presenters are drawn from dental schools in the USA, private practitioners from around the world. To register for future webinars, visit www.hhands.org/dental-training. For future inquiries, contact Facilitator.
Dr. Sultan practices in private practice in St. Louis, Missouri, so just a neighbor of mine over the river. And he is a member of the American Academy of Implant Dentistry, American Dental Association, Greater St. Louis Dental Society, and a member of the Seattle Study Club. It is my pleasure to introduce Dr. Mazen Sultan to talk about complications in dental implant therapy.
Thank you. Thank you. So I'll start here by saying good morning, good evening, and good afternoon, and I will share my screen. Just a second here, share screen. Here we go. Okay, can everybody see the screen?
Yep,
Yes.
looks good.
Okay. Well, good morning, guys, again. My name is Dr. Sultan. Where I practice, they will set it. This is St. Louis, in case people don't know what St. Louis is. We have that big arch that you see in some Hollywood movies. That's our mark. Where I went to school, Southern Illinois is about 4 hours from Chicago. That's the big city. And also Louisville is the state where Kentucky Fried Chicken was found. So that's a fact, So let's start with this case. I always like to say a person who never made a mistake never tried anything new. And I encourage every practitioner. Dentistry is evolving day after day. Try something new, but make sure that the thing you try is just you have a plan. It's just not like, nonchalant and not care about what you're doing. At the end, there's a human being behind every treatment that we do. So that's very important. Okay. So, everybody that walks into my practice, where I practice right now, they always want a dental implant, okay? I want an implant. In this case, a patient walks in, I want an implant. Is an implant a possibility? Absolutely. I can put an implant anywhere, but I always go through pretty much a specific sequence of how can I place an implant, where should I place the implant, if I should place this implant. There's a lot of, placing the implant is the last thing on my mind. I look at this patient, I have to evaluate everything. In this case, we have to evaluate occlusion, inner arch space, medical history, all that kind of stuff. So key points that I personally live by, that I've been trained to do, is key points when planning a dental implant. And any single patient that walks in for an implant consultation, that's the most common thing that we do here in the US. I always health history. We overlook that a lot as dentists because, people don't look at dentists sometimes as, doctors, but we are dealing with humans who have parts that are connected to their body that have a lot of consequences to it. So we have to address everything. Dental history, as we looked at that picture, occlusion, there's a big factor. How often they go to the dentist? Do they get routine cleaning? Are they only a frequent flyer on the program when I have an infection? Always assess patient expectations. That is something I screen for. I have my antennas up, always looking. I have these patients, doc, just take all my teeth out and give me implants, or doc, take them all off and give me a denture, for example. But because they think that's the best, because if you don't have teeth, they're going to fit perfectly and look pretty. But in reality, God gave us teeth for a reason, and our own teeth are the best implant. And last but not least, when it comes to implant treatment, because that's what we're talking about, always have your placement prosthetically driven. In our case right there, that I just showed you a minute ago, in the arch, we could place the implant, but is that implant going to be in a favorable position? Is the implant going to survive? If I put a bridge over there, is it going to survive? So these are things we always have to consider. In the beginning of this presentation, I would like to say that we're going to have a little bit more like lecture thing types, but it's kind of my GPR training going in before we go into clinical cases. So common risk factor associated with implant failures that I always see: smoking, diabetes and systemic disorders. You have radiotherapy, medications, patient hygiene, prosthetic failure and poor design of the prosthesis that we're using, surgical complications, practitioners' experience is a big one, in my opinion. But overall, in all literature that you could read, most two common factors are patient smoking, uncontrolled diabetes. So these are one of the main two things that we're going to focus in this presentation about some of the failures, and also we're going to discuss some prosthetic failures. So a little bit about patient history. You know, people are living longer, aging well, and, you know, diabetes is becoming more common. I really worry a lot about diabetic patients in my practice because, you know, there's a big association between wound healing and preoperatively uncontrolled diabetes. And that's a big factor. Even if it's, let's say it's above 80 milligram per deciliter or below it, you still have, if it's uncontrolled, if it's high or low, you're always going to have complications from my personal history in my practice. So diabetes is the enemy, in my opinion, for dental implants. So I call this the diabetes Bible, okay? This is the chart that I use in my general practice residency and I use in my private practice. If the patient falls in the ASA 1, 2, 3, well, 1 is pretty healthy, 2 and 3 category, you know, I mean, I'll let you guys kind of read the tab. I'm not gonna, you know, read it for you. But as long as for me, main factor HbA1c is more important to me than the, you know, fasting blood glucose levels, because it depends on the patient, how their diet was in the last day. But the HbA1c will tell you the patient's died the past 3 months, the past year. So I personally, they recommend if it's below 9, you know, if the patient has it controlled and they always have it over like the past 3 tests below 9, that the patient has it under control. But I usually take the average 7 plus 9 divided by 2. So pretty much I go about, if you're above 8, I kind of become more cautious. So these are things to factor in, okay? Smoking, as I said, is the enemy. You know, there are of course some failures in my practice that happen because of occlusion, but the main failures I encountered is people who smoke, people with uncontrolled diabetes. I cannot emphasize how more important it is to just not overlook that medical history, because I will show you some cases and you live and learn, okay? A lot of studies in the Journal of Oral Medicine, Journal of Oral Implantology, a lot of studies that show a lot of factors that affect the survival rate of dental implants is smoking and uncontrolled diabetes. So I would like to share a study. This is a really old study about Bain, 1993, that showed that the outcomes of more than 2,000 implants over a period of 6 years, and overall failure was only 5.92%. But what they decided to do is take those failures and categorize them to smokers and non-smokers. And out of those 5.92%, 11.28% of the almost 6% smokers, implants failed. And the non-smokers, only 4.76%. So if we do the math, 7.7% of the failed implants were smokers. So pretty much smoking increases the risk of failure by 2-fold or 2 times that of a regular non-smoker patient. So it is statistically significant that, you know, smoking is a big thing. So are dental implants successful? Absolutely. I mean, I personally have an implant in my mouth and it's been there for 6 years. Thank God I don't smoke. I'm not diabetic that I know of, but, you know, so I check the box at those 2 marks, but of course my occlusion could be better. So that's things that we have to consider also. But the main 2 factors that I worry about when it comes to surgical failures in my practice, you know, smoking and diabetes. But as we know, nothing is 100%. Even in the hands of the best surgeons in the world, things happen, okay? So how we define failures? I like to use basic principles by the Alperson criteria. A survived implant, an implant that's in your mouth. A failed implant, an implant that's out of your mouth, you know? And of course, he defined failed implants as also a mobile implant. So people have implants in their mouth, but they're still mobile. Early failures is inability to establish osseous integration And the late failure is the inability to maintain or achieve the integration, which is pretty much we're talking about patients with 10 years of implant function, then all of a sudden the implant falls out, okay? So, we're done with the lecture part, but I just wanted to kind of have an intro so you guys can see like how I kind of go through the process of when I place an implant on a patient. I just don't go and place the implant. Placing it is easy, dealing with it later is the complication. And of course, an unhappy patient makes for an unhappy day, unhappy dentist, a lot of headaches. So we're going to start with first case right here. A 59-year-old female present to our clinic. She has an upper denture, terminal dentition at the bottom. She only has 21 through 27. Severe decay. Her medical history, depression. She has rheumatoid arthritis. She has hypothyroidism. She's not diabetic, but her social history, she's a heavy smoker and she's obese. And we know sometimes obese people just are pre-diabetic sometimes, so that's stuff we have to kind of consider. Her meds, she takes Enbrel injection, which is an injection she takes for her rheumatoid arthritis. Duloxetine and method for her depression, methotrexate to help her arthritis, and Synthroid for her hypothyroidism, okay? So the patient wanted an overdenture, okay? She did not want to have a regular denture. She heard how horrible they are, and she had a very shallow ridge. So we decided, you know what? We're going to discuss with her about her smoking. She's like, oh, I only smoke like 10 cigarettes a day, and I'm cutting on it. I was more worried about the rheumatoid arthritis as well, because sometimes those medications, especially that she's taking injections, suppresses your immune system a little bit. And there are studies that show that could affect also, implant osseointegration. But I mean, we discussed with her all the pros and cons of everything, and she decided to go ahead with the procedure. So we took a CBCT, as we talked, just because I liked it, because I can sometimes in specific cases. We took the CBCT. She had some areas that we can place the bone, but we went with the immediate approach because of how thin the ridge is, and I was worried that it will resorb more after the extraction. So pre-op, that's how she looked. That's the panel. Post-op, we went and placed the implants. If I look back at this case, I probably would have placed it a little bit deeper, but I was happy with the placement for an overdenture. It was good enough. The implant torqued out. It was stable. Patient lives in Alaska, apparently 8 times of the year, 8 months out of the year. So she said, I'll come back. So coronavirus happens. I don't see the patient for 8-9 months. She comes back. I take a PA before I look in her mouth. I'm like, I need a PA. Boom. Bone loss everywhere. Patient has no pain. There's no purulent drainage, no swelling. Patient's like, I'm ready to get some teeth. And I'm like, we need to take a scan to see how extensive the buccal and lingual plate loss is. So we take a CT scan. This is a lateral view. Pretty much no bone. Where did the bone go? I don't know. I promise when I placed it, there was bone. So I'm more of a visual person. So whatever I place, I kind of have to look buccal lingually, make sure my STI. So I look at this case and I'm like, man, I need to break this woman some news that the implant failed. And she didn't even think it failed because she has no pain. She's like, how could it fail when I'm not in pain? Of course, patient sometimes have implants fail, and like people have bad teeth that hurt infected and they don't hurt. So I explained to her that the implants failed and we have to take them out. So based on the medical history stuff that we discussed a minute ago, I mean, did I miss something here? That's what I started thinking. Did I miss something? I mean, there's a lot of red flags that maybe I should have paid attention to. Like, is she a diabetic? Is she a compliant patient with her oral hygiene, regardless, even if you don't have implants or teeth? Smoking? Was she really only smoking 10 cigarettes a day, which I found out she wasn't, and she was smoking also recreationally? Medications. Was her osteoarthritis bad? Those injections, did I not look more into it and how long she's been on them? And also one thing that I noted, I've been talking to a lot of other colleagues about, when you do an immediate placement and you put an immediate denture on top of it, that denture is never stable. And that patient needs a lot of adjustments. So something to consider is that you want the patient to come in very frequently. In our case, this patient was leaving town. And when she came for me 8 months later, she had epialis fissuratum, which I wish I had an image of it, is just because ill-fitting denture, it kind of moved all over the place. So it could apply pressure on the implant, which bone does not like pressure. So that could have caused us some bone resorption. And that's when I was first saying, I wish I placed my implants deeper, because maybe there would be less pressure on the implants, less bone, loss. So took my failure like a champ, went over her medical history. We decided, we will replace these, but we have to get on some Nicoderm patches, work on our smoking, get a little bit medical consult. Patient is pre-diabetic. She went to her doctor, so she's on the edge. So we're going to make sure she's always controlled. And 2 weeks ago, we just took them out and placed them in, okay? There's a lot of things to learn from this case, but I like to kind of start with management. So patient medical history is a very big factor when you do implants. You can have all that bone, and when you drill into it and it does not bleed, for example, with a patient who has osteoporosis or arthritis, that implant does not have a high chance of survival. Blood is key for implant integration. So these are factors we have to consider, guys. Case number 2. So now going to a little bit back to just, a simple case. A pros. This is more a pros failure, okay? So patient comes, complains, man, doc, this implant crown upper number 3 keeps packing food, and it's so sore, but I don't know why. It's not loose or anything. So to be clear, 3 and 4 were splinted together, okay? I look at the PA, I'm like, it looks fine. I mean, nothing looks major, but I like bite wings always on implant crowns just to make sure everything is seated. So we take a bite wing, what do we find? An unseated abutment crown. Well, this is splinted together. So what happened here? This patient's been doing this for 2 years. So, I'm glad the implant didn't fracture, because he didn't put stress fractures at wrong places. So it's very important here, just from a pros perspective, just, from restorative, this is a basic day complication. Always take a good bite wing. Assure seating. Okay. So I sectioned the crown together, took it off. You see all that inflammation under the gums. We clean it up. We irrigate it with chlorhexidine, place a new healing abutment. Bone level is still acceptable, a little bit bone loss there, but implant stable, no complaints. So we kind of learned from this case that we have to always verify seating, especially with splinted abutments. So what could have been gone wrong here? Impression copings were not seated the day we took the impression. Or what could have happened wrong? A distorted impression. Just easy. The lab technician did not push it down all the way. A third, it's very important to, when you do splinted abutments, that you have non-engaging abutments. When I say non-engaging, I mean pretty much they're like cylindrical, but with no notches. So when you put your abutment into the crown, it has no key and a lock fit. It just pretty much passes, it fits in and out. That helps assure complete seating and proper fit. So these are, I just wanted to address some basic process. I run into this a lot in my practice, especially with people who just, wanted, implants in a day, or, a $500 implant in a day with final crown, pretty much people, trying to get people through the door without just properly, treating the patient. Case number 3. Now, this is a little bit more process-driven as well. So, 65-year-old patient walks into the clinic. This is with this was the predoctoral student, and I was the resident at that time. Student grabs me and said, this patient has come to him the last couple of years, multiple times since he became a student in the clinic, and this implant bridge, keeps coming off every single time. Every couple of months, it's off. So we decided to investigate it together. Of course, x-rays, implant solid, no pain, no purulent drainage, bone looks good, no gingival irritation. So I decided to take my perioprobe. You can tell how that canine pretty much and the premolar go down pretty low. So when we look at it, the inner arch spacing, at the premolar, it's almost 4 millimeters, and at the molar, maybe we get 4 or 5. And of course, second molar area, we always know that's the worst area, or prepa tooth. So in this case, I believe that we kind of violated the minor principle of you need to have adequate restoration, thickness, and height. So when I say thickness and height, you have to have an adequate height for your abutment. So when you do a cement retained restoration, you have to have at least a 7 millimeters so you can have enough height of your abutment. We see these abutments are pretty short. They're about 3 millimeters. And we only have 5 millimeters. So in this case should have been done screw retained. Absolutely. I think this patient is gonna, well, this patient got a screw retained restoration after this. And since then, I haven't heard back from them, but of course I finished residency. But these are things we have to look into in a daily practice. I mean, these are cases that we can encounter every single time. You know, it's not, you know, nobody's going to always have complicated cases every single day and implant failures. I mean, to me, this is a failure from a prosthodontic perspective. I mean, you have the implant, but if you can't use it, what's the point? And if this patient every day is on your schedule, limited exam, cram off. I mean, we have to look into things more. Okay. So this patient got a screw retained bridge again after this, and he's happy. Now, this case is going to talk into what we were discussing about CBCT and how CBTs can be very important. So 70-year-old male here presents to us, very healthy guy, very nice guy. He lives on a farm. He has an upper denture, but he wants a bottom over denture because his bottom denture, you can see the canines are bad. So I'm like, oh, absolutely. They call me Dr. Sultan. We have this patient that wants implants. Can you come to our clinic and place those implants? I'm like, let me look at the panel. Oh, wonderful. Patient got a lot of bone. Look at the height. But I'm like, you know what? Let's take a CT just because we can, right? So we take a CT. Look at that. I mean, talking about is CBCT important? I mean, per case, I mean, look at that ridge. There's no ridge. It's a knife edge. And if you notice, if we go right here, I mean, also we notice there's some blood anastomosis in that segment 54.8. I mean, there's a lot of anatomy. Before we used to just, think about the mental frame in between arch, inner arch mental framing area is a safe area just to place implants without worrying. But no, now with CBCT and all the other stuff that we can get, we notice that there's more blood vessels and things we have to watch out for. So I'm like, wow, I got fooled. I was so excited. I'm like, we're going to place 5 implants here. So don't let the images fool you guys. Sometimes if you cannot get a CBCT, of course, maybe we could palpate and see, but that buccal curvature and concavity, you really got to feel for it. I did not expect it to be that thin, but of course. So in this case, what did we do? I discussed with the patient, like, listen, these are your options. We can send you to an oral surgeon because, you're probably going to need a tibia-fibia graft and some, to get some really nice ridge. Or pretty much we do some serious alveoloplasty, hoping we get some thick bone and place a couple of implants. Or 3, just, you might have to live with this lower denture. So, of course, we went into pros and cons of every procedure. Every time I go, I explain myself because you explain it before the procedure, it's not an excuse. But if anything wrong goes after the procedure, it's definitely an excuse in the patient's eye, even though you are doing your best. So he decided to go with the alveoloplasty. He's like, listen, I like you, doc. I don't want to do another ridge augmentation, and I want to go faster. I want this treatment to go faster. But he did not know that we're going to have a pandemic and things are going to slow anyways. So what we did, I did it. You see the big alveoloplasty that I did? To reach enough to place, I placed Straumann implants here. I'm not advocating for Straumann or anything. I placed a 3.3 by 8 on the lateral area. So I'm talking about more like 27, 28, 22 area. And I placed a 3.3 by 10 in the middle area of 24, okay? I attempted to do this case guided, okay? I had to place a big flap and do a bone reduction guide. Guess what? The day of surgery, the guide didn't fit. So, and the patient was flapped open. He was my whole day schedule kind of in the morning. And I'm like, but I was confident in my training myself and I already had a CT, so I know what to do. I know I had to go 10 to 12 millimeters of bone reduction. So I reduced this patient up to 10 to 12 millimeters of bone reduction, kind of eyeballed it. And, everything went well, but, the guide didn't fit. So I always tell people, don't rely on your guide 100%. Sometimes it could fail you. So of course, this was, intraoperative replacement. Those edges were rounded off and we'll have some images, okay? So what was the disadvantage of the treatment option that we did today? He's definitely going to have a shallow vestibule, possible nerve anesthesia, mental area. Think about it. We're reducing 12 millimeter of bone, laying that big flap. I saw the mental nerve. I actually, marked the area where it is so I don't cut it with my drill. And also patient already lacked keratinized tissue. So that's a big deal we're going to come back to, especially that he's going to get a removable prosthesis, okay? And he has already a shallow vestibule from the beginning plus now. So Patient actually did experience some intermittent mental nerve paresthesia on the right side. He only felt it when he was shaving, but it got better in, because I know the nerve was intact. It just, the flap kind of irritated it. So now he feels normal, As for the vestibular and keratinized tissue, we decided that we're going to do kind of a full free gingival graft that was done 2 months after the implant placement, and I luckily had a periodontist and I was working with in the same office that we just decided to work on it together. And I always go by the principle that you have to have keratinized tissue around the implant to survive, because you know what, in some cases you'll see bone loss, but as long as you have thick tissue to support that implant, at least 2 millimeters attached gingiva, okay, it has to be attached, okay. It's very important, because a lot of cases fail because, they look great the day of placement. 2 years later, all that brushing, aggressiveness. As they say, bone sets the tone, but tissue is the issue. So always make sure you have thick tissue around those implants, okay? So this is how patients started after 2 months after, and free gingival graft. Big difference, I think that will help the survival, especially taking into consideration, the aggressive nature of the surgery that we had to do to help this patient, get some implants. So, of course, we had to do an uncovery. Uncovering was fun, very fun for this case, because of how deep the implants were placed and all that stuff. Of course, this might look like a root tip, but I promise it's not. It's just some weird shaped bone. So uncover the implants. I placed customized healing abutments so I could control the height, because I needed a pretty deep implants. Because implants were placed deep. One thing I noticed is when I uncovered, bone was covering implant number 22 and 27, let's call it. But implant 24, I noticed that there is some bone loss. And that's the funny part. That was the longest implants I placed and the most confident implant. I have enough thickness at that spot because it was a little bit closer to the middle. And we had approximately 1.5 threads kind of bone loss. But I tested it, passed the torque test. We have good keratinized tissue. And second, I discussed it with the patient, and it was the middle implant. So it wasn't like the implant on the border that's going to support the prosthesis that we're going to make. The patient was like, you know what, doc, I don't want to take it out if it's stable, and I want to get some teeth. So we agreed that, you know what, we're going to monitor the situation, and we can keep going. So this is how the patient is. Those are the customized healing abutments. Very stable. This is our wax try-in. And this is patient smiling. This was and of course the bar is in fabrication. So this is our final planned restorative option. Of course, it's 3 implants, not 4. So this is from another case that I have because the bar has not been finished yet. So this is our plan. The patient's going to have a bar like this. With some locators on it, and it's going to give him some nice retention and support, especially with the ridge that he has. I thought locator dentures will not do it for him. So I'm very excited for this patient. He's excited to be done. The pandemic kind of held up a lot of this treatment. This should have been done almost a year ago, but everything happens for a reason. So learning objectives. Use a CBCT when you can. Saves yourself a headache. I understand CBCT. I personally, in my other office that I work on most of the time, I don't have a CBCT, but I have a good relationship with an endodontist that has a CBCT. So when I have a case that I'm kind of feel like I need a CT for, I just send him to the endodontist, and he will kind of get the scan done there, and I'll have it on a CD, and I'll upload the data and kind of look at it. Never rely on your guide 100%. And I know a lot of general dentists just feel like the guide is their safety net. Absolutely. But if you don't know how to kind of manage a situation where a guide did not fit, like in my case, then pretty much the patient will be angry. They'll feel you're incompetent if you couldn't manage a situation where the guide just didn't fit, because free-handed placement does not make you a less superior dentist if you don't place everything guided. Okay. You just have to have the skill to visualize mentally, how implants are kind of 3-dimensional, and use your imaging as a guide for yourself. And always present the patient, with all their options. I did not tell him, hey, we have to do the alveoloplasty and all this. He was presented with other options, but he selected the one that he thought that would work for him. is implant number 24 an issue? You know, we do have, you know, a couple of threads, you know, kind of lost, but nothing is showing in the mouth as I showed you in the image, but we have thick tissue. I mean, I personally am not as worried. First of all, it's the implant in the middle. God forbid this implant failed, that bar is still functional. 2, patient is 70-year-old. He did not want to go through surgery again. I torque tested it, 45 Newton centimeters, and still stayed, did not move. So I feel pretty comfortable. Of course, I would rather have no bone loss, but in this case, we lost some bone, but it's stable. And luckily, that was the longest implant that I placed. And the reason I went with short implants on the other side, just because of how close I got to the border of the mandible, and I wanted to get have at least 3 millimeter space between that and the border. So if it becomes an issue, we can remove the number 24, and the bar is still salvageable. Again, you know, because the lateral implants that we place are stable and functional. Case number 5. So this is personally my favorite, not because it has a lot of complication, just because of how you kind of deal with it. Okay, so this patient was a teen when she got in a car accident. She lost her, let's call the teeth, 8, 9, 10, alveolar ridge bone. So she had to get a lot of grafting done by oral surgeon, tibia grafts, mesh, all the stuff when she was a teen. And her dad is a dentist, so this patient is high maintenance. You have to think about it like the parents are going to be the high maintenance, not the patient themselves. So she had the 3 eye external hex implants placed 20 years ago by an oral surgeon and oral bone grafts, okay? So due to the alveolar bone loss, we have bone loss. We had the alveolar bone loss. So the prosthesis, like, you know, had to be made in a way that, you know, she's 20 years old, okay? She's not trying to look like she's 70 and she lost her front teeth. So we had to make a prosthesis that would give her some lip support, but at the same time, look pretty. So, I mean, not a lot of people think, you know, removable could be a fix. So, but it can be. So in her case, we did something called a spark erosion prosthesis, okay, back in the days. And we made her one too. We'll talk about it. She loved it. Give it lip support. It was, I call it fixed removable because it's literally feels like it's an all-on-4, but it's not. You can take it in and out and clean it, but you can sleep in it. And she came to me because she wanted me to make her a new one, so and all that kind of stuff. So we'll discuss this case. So I was going to show what an image of a spark erosion is. So we have this bar fabricated, okay, and on top of it, like it's like a denture that slides in, and if you notice right here, we have a key that locks the denture in, okay. So what that does, it pretty much literally, and the intaglio, well, that image disappeared. There was another image I could show. The inside of the denture has another bar. And that bar would help you kind of, it's a friction fit prosthesis. So it's fixed removable, believe me. It fits better than an all-on-4 in my case, believe me, in some cases. It feels like it's an all-on-4. Nothing like, patient loved it. So, you know what, I'm like, absolutely, I'll make you a new one. I got this. So we go in, you know, patient comes in, take the old bar off, apply the principles that we talked about before. We have to put the impression coping. If you guys have never done an impression coping for an external hex, it gets a little bit tricky. You have to, you know, it's a feel thing. You feel like it's in all the time, but it really isn't until you take multiple x-rays and verify its seating. That's very important when you do an external hex implant. So guys, always realize that it might feel like it's seated the right way because it can go in multiple ways, but you have to take a couple of x-rays. So I use Improgum, you know, very common impression material for, you know, when you want to fabricate bars and stuff. I took it all, took the impression and sent the patient home. No big deal. Patient comes back to verify the impression coping the model accuracy. And she's like, tooth number 7, man, it's been sensitive since the day we took the impression. I'm like, really? So let's take a PA. I take a PA, horizontal root fracture on number 7. I'm like, how did that happen? What did I do wrong? I mean, did the impression, like, did it snap when I did the impression? I mean, I couldn't like realize like an impression could really cause a horizontal root fracture. I mean, luckily, I mean, if I was me, I'll probably have been pissed off, blame the dentist for this. But I mean, should I block the undercut under that? But I mean, you couldn't predict this happening. So, but luckily the patient was understanding. But now she wants me to do a spark erosion bar with an immediate delivery of the bar. You know, that's not something easy to do with the prosthesis itself for aesthetic purposes. But we managed to work it. I had a really good attending. So what we did, we took the tooth out of occlusion. We continued with the bar, fabrication steps, very important steps. Make sure the bar fits well first, and of course, prior to the bar being made, we always have to do the wax drying, okay? That's a key factor. When we fabricate anything that has a bar, or pretty much anything that has a bar, we have to make sure we do the wax drying before we make the bar, guys, because the teeth position will decide where the bar goes. But if you make the bar before you do the wax drying, the bar dictates where the teeth. And the teeth then, because you have to have adequate thickness of material between the tooth and the bar, and that could, that's where most of the complications happen. When people fracture teeth off, all on fours or off bars because of that situation. So we always do that. So we did that. Wax drying went well. She was happy. Of course, some tweaks here and there. Make the bar. And I verified the bar in the mouth, but also I was lucky that I could also use my model to verify her old bar on it, because, if the implants are stable, it works. Because, if you remake this whole prosthesis, you have to make a new bar too. It's kind of a frictional fit, custom made, one-time use. When it's done, it's done. Did the jig and everything, did the surgery, extracted the teeth, did the tooth, delivered it. And that's how the patient looked the day of delivery. She was very happy. That's how it looked in her mouth, intraorally. She was very satisfied. Of course, we can see she has a cant. I can't correct that, but she would need a lot of stuff, but she was very happy. I was happy. A good day. So what did we learn from this? Each patient is different, okay? No one treatment fits all. You got to think about it from perspective. I know a lot of people would have thought, we can just do an all-on-4 prosthesis, or like in her case, all-on-3. Why did you go back to the bar? Well, first of all, patient was comfortable. 2, she needed the lip support, which I think I can give her better with a flange. And third of all, cleansability. This thing, you can just take it in and out. Maintenance on it is very low. This prosthesis survived for 20 years, another 20 years. No screws really required, replacement, nothing like that. Of course, disadvantage, it's always going to have to be acrylic. It can't be zirconia. And we move on. Always, and we will move on back. Always pay attention to the patient classification, what falls into. So we're talking about what Carl Misch, teaches is FP1, FP2, FP3. FP1 is when the patient's only missing a tooth, as we know. So we only replacing the natural tooth. FP2, we're going to replace some of the tooth, but with some roots a little bit, so the tooth will be longer. And what our patient falls into is the FP3. We had to give her some pink to give her lip support, to give her some bone back, but also at the same time, we have to give her some white, which is her teeth. So at the end, what I learned from this case, first of all, the prosthetic part was really great to learn, but also it's a complication management. This was not an implant failure, but this could have become an implant failure. What if the patient decided, I don't want a bar, I want another implant, I want single units, and you better make it look good. So you always have to be prepared no matter what happens, okay? So we took an impression, fractured the tooth with the impression. It was supposed to be just a bar impression, so always be ready, trust your training, and communicate with your patient. Patient trust, reassure them. I literally treat patients like they're my little parents sometimes. Like, it just kind of gets annoying to them and me, because I just make sure, because that would avoid complications. And if complications happen, you already have the patient's trust. They know you're going to do whatever it takes to make it work for them. And that's the most important thing. Always talk to the patient long enough time, okay? They did a lot of studies. This is on the side. A lot of studies about, malpractice and legality issues. And they noticed that, patients who on average, patient-doctor relationship, doctors who spend an average 3 minutes longer explaining things to their patients, okay, than doctors who just go in, do the procedure and leave, are less likely to get sued if something goes wrong, okay? I'm not trying to say, oh, do bad dentistry and just be nice. No, but I'm just saying communication reduces your implant failure. In my head, implant failure means headaches. So I hope this was a useful presentation. I hope somebody learned something from this. I always tell people a failure will never define you, and it's never a failure if you learn from it. It's a failure if we just decide to ignore it and not learn from it. This is what I have for today. Hand this back to Dr. Onoriobe, and if anybody has any questions, let me know. Thank you.
Thank you so much for such a great presentation. Please, if you guys are, those of you who have listened, if you have any questions, put them either in the Q&A box or the chat box. We have some nice comments coming in already. I had quite a nice turnout today. I was kind of curious if you saw any research when it came to if someone was a smoker in the past and like say that they stopped smoking like 5 years ago or something, how much of an effect that might have had. Did you come across that?
I mean, I didn't come research through that, but if you look at it from like the biology standpoint, I mean, if you go to any clinic that says, cessation smoking clinic, I mean, they tell you like within 24 hours, you see the difference, and 3 months later, the blood flow. So if you're 5 years later, I mean, pretty much beside the systemic effects, I feel like on your lungs and your blood vessels, I feel like this is not like a medication. It's pretty much just the nicotine and the other smoke in it, the poison I call it, is what really affects the healing blood and the smoke itself. So I feel like from my personal experience, I don't think 5 years, I mean, that's why we get them to quit so we can place the implant. So I don't think there's a lot of studies on that. It's more about actively involvement in that.
Very true.
All right, so thank you so much. Do you guys have any questions? If you have any questions, okay, yeah.
Oh, we got one.
Okay.
What do you think of using Ostel to check for stability before loading? Do you do it all the time?
I actually think it's a great tool. Unfortunately, at that time, I did not have access to it. And actually, I wanted to last minute, I should have added it to the presentation. But Ostel actually is a great tool to use. If people don't know what Ostel is, it's pretty much a device that kind of gives you wavelength stability of your implant based on the day of placement compared to the day of restorative, and you want it to be always above 65 to 70, and that tells you that the implant is osseointegrated, and it's a great tool to have. It does get, I'm not lying, with implant dentistry, all these extra toys get expensive, and for a practitioner who's only been practicing for 5 years, you got to be picking point. You want a CBCT, I want an Ossetel, so you got to, kind of plan your toys accordingly. Your dental toys, I call.
All right. I do have Dr. If you have any more questions, please. I'm going to check on Facebook if somebody left a question there. But Dr. Adeshina, I know you place a couple implants. You place a lot of implants in Nigeria. What's your experience with with smokers? Do you have any experience with your patients who been smokers?
Yes, we have some patients, but we are selective with patients. In our environment, we make sure that patients are non-smokers, and the other, patient selection criteria are done. So we really don't have to contend with those confounding factors when we do implants.
Okay. Now, I'm just going to ask you straight away: have you lost any implants since you started placing?
100% osseointegration so far. No, we have not.
Okay.
That's awesome.
You are a lucky guy. I'm telling you, when you place if you place long enough and you stay in the same place where you place them, somebody say for you to really practice dentistry, you need to stay in that environment for 7 years. That some of the complications start coming at the 7th year. That's a good thing, though. That's a good thing. Congratulations.
Thank you.
Anyway,
thank you.
Yeah, it's been Dr. Sable, what's your experience with implants in terms of people that come with failed implants already, in terms of that they are presenting complaint? What have you experienced?
We are talking.
There's one patient that comes to mind during the fellowship who someone else had placed the implants. It was an all-on-4 prosthesis, and we were supposed to make the restoration, the hybrid, and the oral surgeon had sent me something saying, hey, make sure you, we placed 3 of the implants, and then we waited another 5 months, and then we placed the one at number 9, and you might want to double check that before you do the hybrid. And I'm like, okay, so we take the CBCT, and the patient said, he's like, if I press on that area, I feel pain. I'm like, not good. And so take the CBCT, and not only was 9 failing, but so was 14, that area. And so 2 out of his 4 implants failed. And so now, go have the discussion with him that you are going to be delayed probably another year, because now we have to take those 2 implants out. And we sent him back to that oral surgeon, and but the oral surgeon was his relative, so don't work on your relatives. That's that's what I'm learning. But yeah, and so had to take those 2 implants in, bone graft, and then place a couple more implants, which brings me to the importance of not using just 4 implants, especially on the maxilla. 5 or 6, that's how we were taught in the Implant Fellowship that both Dr. Sultan and I went to. So, yeah, it's a hard conversation to have.
Nice. Is there somebody from Uganda? If you're there, Patrick, if you want to speak, just raise your hand up so I can identify you. Dr. Ikimi, I know you've been placing implants. Dr. Ikimi is from Nigeria. Can you hear me, Dr. Ikimi?
Yes, I'm here with you.
All right. So do you have any experience with implant complications?
Yes, I've actually had 2 implant failures, and that was due to poor oral hygiene of the patient. When I recalled them, 3 months recalled after placement of implants, they didn't turn up, and they came back a year later, and they came with the implants on their hands. And so I noticed poor oral hygiene. But most challenge I had was that the crown rotates. So what I do now is I make some indentation on the abutment, take impression with the indentation on it, and then send it to the lab. When the zirconium crown comes in, it fits into the indentation like a lock, and then I don't have a problem with rotation anymore.
Okay, that's a smart one. So you use that cement retained, I believe, right?
Yes, I use cement retained. But I learned that the screw retain is much better. But for now, I still use the cement retain.
Dr. Sultan, you have any comments as to
about the cement retain and the screw retain?
And just the rotation in terms of that type of complication.
Rotation?
Yes.
I was talking about path of insertion because I did not understand exactly the question. We're talking about the path of insertion?
No, he says that he has had complications where the patient return and the implant is rotated. It keeps kind of turns on the abutment.
The implant turns or the abutment turns?
No, the crown turns on the abutment.
Okay, so actually, my mother has something placed in something somewhere else in a different country, and she has the same problem. And the problem is people are not using abutments that are actually true to the implant system. Like they just stock abutments, and a lot of these abutments actually they don't fit tight. They're not locking. So the abutment itself, the screw keeps loosening all the time. So that's why every time you screw the crown, it kind of keeps turning. So what I would recommend for his cases that he notices that happening, to actually make sure that abutment is actually authentic to that implant. Does that make sense? It has a true fit, because that's the major issue that happens. And that's, to save costs, because, when you use an authentic component, sometimes it might be a little bit more driven, but that's one of the main things. I've had a couple of cases, and actually my mother is a victim of that case as well. Mm-hmm. So
that's a great advice. One more
question there.
Yep, we do. Please tell us how you manage failed implants. How long do you wait before placing again?
Okay, so it's case by case. In that case, the smoker lady, I actually, two weeks ago, I took it off. And just because I knew, her problem was I don't have enough bone. So, and she doesn't want to go through a lot of surgery, and she's going to go back to Alaska. So as long as me and her manage that smoking thing for a couple of weeks, we got a verbal commitment, but I can't go home and baby her. I actually, depends on if I have enough bone to place it the day I take it out. I actually took him out and placed him the same day, especially for a bridge, for an edentulous case, that's different. Of course, if you're placing number 8, okay, and it failed due to infection, and let's say no buccal plate and lingual plate are gone, then you have to wait, as if you did a ridge augmentation, which you have to place the bone, if you have to put a membrane, a mesh, let it heal. So each case is different, but with edentulous cases, I guess immediate placement as the same day of failure is always a big possibility.
Dr. Franciscus, you are from Indonesia, right? Dr. Franciscus, can you hear me? You have permission to speak if you would. I just want to see, seeing people from different countries here is just amazing. I want to see if you have any, from your own what you experience in your environment. If you can hear me, go ahead. But we are rounding up, and I'm just looking at who is here and what experience you have in your country. And if you want to speak, if you have any comments to make, if you think you would like to speak, you can just raise your hand, and I would give you the microphone.
Did you like the CBCT requirement on that case when you were discussing the need of CBCT? Yes.
There's one. The first case you showed, the first case, I was wondering, could there have been in terms of leveling? I noticed that was there
exactly
consider flattening the
alveoloplasty, and that's what I said. I wish I placed it deeper and flattened it, but I'll say I could have done it better. This way you look at the case, but at the same time, I'm also patient. This patient is just something else. Let's just say. I mean, I was surprised I was able to even do the surgery on.
I know. I mean, some folks don't. I had a patient who needed alveoloplasty. Like, there's no way anything would stay there, and he said the alveoloplasty part he does not want. I mean, we have to almost dismiss him. Like, I'm not going to, our name is going to be on this thing. We're not going to put it.
But I absolutely, yeah. That's why, I mean, I present my failures and say, I mean, I'm not like just everything works. I mean, that case, I truly, after I placed it, I wish I went deeper and I did more alveoloplasty. But I mean, I did not expect this, it's still, that should have not caused it to fail the way it did. But yeah, it happens.
I want to thank you for giving us a true life, real experience, because this presentation is the most awesome presentation I've ever listened, because people don't talk about their failures. Most people come and present all kinds of highfalutin cases, but we know that if you do these things, you're going to have failure. And for other people to learn, I really salute your the brilliance with which you have just showed us, so that many people watching from around the world would consider things first. There are so many medication people are on that lead to failure. I saw a case, still speaking, we talked to Dr. Montine about it. That implant needed to be placed deeper, but it was not. And they want you to restore it. They're like, go and meet a prosthodontist to restore it. And we saw the patient yesterday, and they were to break the news to him. We can't restore it. He felt so bad, but you need to calculate the space before you start, and to see whether you can restore something before, you attempt it. So many lessons learned. Next week, we are going to have Dr. Brian Goodacre from Loma Linda University in California. He will be speaking on digital planning in implant dentistry. This guy is a #1 speaker on digital. I mean, in most conferences that I go, he's there. And his father, Dr. Charles Goodacre, one of these days, is going to be speaking to us.
I actually attended a course for him at one time. He's pretty good. He's very good digitally.
He's an awesome guy. And we also are going to have Dr. Natalia de Andrade from she trained in Brazil. She's currently a periodontal resident at the University of Michigan. She'll be speaking on orthodontic assisted GBR phenotype modification therapy for implant site development. Cool presentation coming on Sunday. On Sunday the 27th, please don't miss it. There's none on the 26th so that we can rest. Then on the 10th of October, I can't believe we are already in October. I can't wait for 2020 to be over. Anyway, Dr. Akanshka Srivastava, she's a clinical assistant professor at University of Texas School of Dentistry. She has been on this webinar before, where how to remove a failed implant. That's what she presented on. It was really cool. Because you're going to get there. Once there's a complication, how do you take it out? Some of them are so she presented on that, but this time she's going to be speaking on immediate implant, provisionals. and something we need to learn. She's going to be back again sometime on the 31st of October. She'll be speaking with Dr. Sarah Gordon. So Sarah Gordon is a pathologist. She wants to speak on oral diagnosis. Not too much on implants. So we are moving away to start talking about general things that we experience on a daily basis. We also have Dr. Carlo Poggio. I don't know if you know that. He's going to be on. This is like good news for dental webinar series. Dr. Carlo Poggio called. He said, please, fix me, give me any dates in the middle of October. I'm like, are you sure? Am I talking to the real Carlo Poggio, the one I see on, very interesting presentation coming up. And once we have the poster flyer, I will send it out. But thank you guys so much for coming. Thank you, Dr. Sabo Montaigne. You always bring some color to our presentations. And Sultan, this is, like this, I give it to you. Yeah, that's excellent, excellent. Again, see you guys next week.
Thank you.
Thank you.
All right.
Thank you.
Thank you so much.
Take care.
All right. Bye-bye.
Healing Hands Health Society presents Dental Webinar Series. We have planned a series dental webinars to keep you abreast of current practice. This series on prosthodontics will be via Zoom, Facebook Live. Presenters are drawn from dental schools in the USA, private practitioners from around the world. To register for future webinars, visit www.hhands.org/dental-training. For future inquiries, contact Facilitator